Um, First of all, I'd like to thank everyone for attending tonight's webinar. Nice presentation. I'd like to, first of all, thank both Dr. Jeff Miller for presenting on behalf of PreXion tonight and for our co-sponsor in this event, which is Breus. I think one of the things I wanted to just tell everybody before I turn it over to Dr. Miller is as many of you know, and especially if you have a cone beam already from PreXion, we really do pride ourselves on being leaders in education, and we do a lot of education. Maybe not always the most education though when it comes to specialty education, and so we're really excited and proud to put this particular webinar on tonight specifically for orthodontics and on orthodontics, and we hope you enjoy it. So without further ado, I'm actually going to turn the ball over to Dr. Jeff Miller to get started.
Well, first of all, thank you so much for the opportunity to speak to you this evening. My title of the presentation is "You're an Orthodontic Specialist, Behave Like One. How Cone Beam CT Will Differentiate Us as Orthodontic Specialists." Now, the general population is a bit confused about who provides orthodontic treatment today. They can go to the orthodontic specialist, they can go to the general dentist, they can go to the pediatric dentist, or they can go to places where there is no direct doctor contact. We all know that. But there's also a lot of confusion concerning the general dentist population in terms of orthodontic treatment. Most of these general dentists that start maybe with aligners in their practice, they end up training from the manufacturer of the appliance system they're using. So they rarely have the whole picture. And if you were to ask the general dentist, you would finally find that they would say that the orthodontic specialist does nothing different than they do in terms of, a mild to minor case. Now, that's a different discussion. What is a mild or minor case? But in their hearts of hearts, they think they do exactly what we do, only they do it more efficiently because they can do it for less money. And what this talk is really about is, what is it that's going to differentiate us from the general dentist orthodontic provider, and what is it that we can, how can we visually explain to them that there are nuances to orthodontics that makes orthodontics more complex than what they're told from the manufacturer of the system they're using. I'd like to thank PreXion for co-sponsoring this talk tonight. If you have questions, Rob Gochel also mentioned you can just chat to him in the chat function, and then I'll pause a couple times to take questions. We have 4 PreXion machines in our practice. There's 7 doctors. We have 12 locations, and I can tell you that as 7 doctors, 7 orthodontists don't agree on much, but one thing we do agree on is that we really like our PreXion machine better than the other machines we have. It's worth looking at if you're considering cone beam CT. I'd also like to thank Breus. Breus is a new lingual system. It's got new technology that I don't believe is available anywhere else. We've been using Breus for about a year. And you can check their website out here, www.breus.com. Also, the founder and inventor of Breus will be on the talk tonight. If anyone does have any questions, he would be the one that could answer them most appropriately. Breus is a lingual system that uses a cone beam overlay, and it uses one wire to straighten the teeth. The treatment plans are made virtually using the cone beam CT overlay. And I can tell you that we've been using it for about a year, and it's pretty incredible. I'd also like to thank the American Association of Orthodontists for promoting the talk tonight. I'm sure everybody listening is probably a member. They're a great organization, and they do really a lot for orthodontics, especially in this current environment. Okay, so we've all seen these ads for 6-month smiles and fast braces. These are systems that are marketed primarily to non-orthodontist orthodontic providers. Okay, the training that goes with these systems is usually taught by these manufacturers. And if aligners are the gateway drug to orthodontics, systems like these are probably like the crack cocaine. But in the general dentist world, you know, how are they measuring the success of their orthodontic cases? And I would tell you that most all of them, there's probably some exceptions, but most all of them measure their success only by the mechanical alignment of the clinical crowns. In other words, if they can get the clinical crowns aligned, then to them, that's a successful case. There's really no consideration for the positions of the roots or the alveolar bone that supports those roots. And the minute you can visualize these things, you can do a better job of explaining to the general dentist, you know, what we do as specialists versus just being a clinical crown jockey. We all know the studies about changes in arch dimension, especially when it comes to the changes in the lower intercanine width. And pretty much all that literature points in one direction, and that is the more you change it, the less stable it's going to be long-term. With the use of bonded lingual fixed retainers, that discussion, or that discussion point for orthodontists, has kind of taken a back seat. You know, think about the last time you were at a meeting and you heard a speaker talking about long-term retention, or you saw a journal article about long-term retention. And while the bonded fixed retainers may allow the orthodontist to break many of the traditional accepted theories of orthodontics, at least in the short term, I believe there are consequences long-term. We also know about Andrew's 6 keys of normal occlusion. He studied 120 patients, and he looked at where Mother Nature placed those teeth in an ideal arch, or what he called a normal occlusion. And he came up with his 6 keys in 1972. Now, as far as I know, the Homo sapien has not evolved, or the dental arches have not evolved significantly since 1972. So when you hear orthodontic speakers saying things like, well, I like my bicuspids a little more upright, or I like a broader, wider smile, most of that contradicts Andrew's 6 keys of normal occlusion. And in my opinion, that's not behaving like an orthodontist. Orthodontists should be held to a higher standard because we're specialists. So if you want to be held to a higher standard, you need to, behave like that. This case I pulled off of Google. It's surprising how many orthodontists have this same case on their website. And certainly this patient couldn't have been treated by 250 people, different orthodontists. But I can tell you, if you show this case to orthodontists, you get a polarization of opinions as to whether this is a successfully treated case or not. You get anything from, yeah, that looks fantastic, to, I believe that's malpractice. So where does that disagreement come from? Orthodontists are probably the smartest people on the planet. And how do smart people look at the same case and disagree so much about whether it was a successful result or not? And I believe a lot of the disagreement in orthodontics has to do with the inadequacies associated with cephalometric analysis. For example, if you have a lower arch with 8 millimeters of crowding, and your treatment uses a broad lateral development arch wire, and you expand the lower intercanine distance 8 millimeters, the anterior posterior changes to the lower incisors on a cephalometric x-ray are going to be minimal, because the decrowding came from the widening of the intercanine width, which cannot be measured on a cephalometric x-ray. So it's almost as if these broad form arch wires are gaming the system. They're developing the arches laterally and using a measurement tool, cephalometric x-ray, to measure the positions of the anterior teeth. Cone beam CT adds another layer of observation. You can look at the changes to the cuspid width radiographically. You can see if the cuspids were tipped out of the bone, and you can see what else happened, because you can look at individual teeth versus trying to look at a wide focal trough cephalometric x-ray. When you start looking at cone beam CTs, it becomes abundantly apparent that the alveolar housings vary in shape and size. And these are just two examples of different alveolar housings for the lower incisors. Cephalometrics does not have a consideration for the alveolar housing. There's no measurement to look and see how wide or thin or the angulation of the alveolar housing. You can't see it with a cephalometric x-ray. You need a cone beam CT, because the cone beam CT eliminates the wide focal trough and allows you to visualize a single tooth from all three planes of space without the obstruction of the adjacent structures. Now, I'm sure all of us have been in a situation at one time where we've been to a dental meeting, or we bump into a dentist and the dentist says something like, you know, I just took an aligner course and I'm just treating the simplest cases, and, you know, you're still going to get my more complex cases. Well, that's fine. And in my imagination, I always think that I'm going to say something different than I actually say. But this is a simple case that was sent over by another orthodontist who's very familiar with cone beam CT. She estimated that this retreatment case would take 3 or 4 months. And then she looked at the lower arch after she started alignment and noticed that there were torque issues. Generally, orthodontists that are versed in cone beam CT will look at the cone beam CT before they start torquing teeth. This is the reconstructed pan and ceph from that patient's cone beam CT. It's not the greatest job in the world, but it doesn't give you any insight at all to what's actually going on here. From a pan and cephalometric analysis, this is a very, very simple, straightforward case. But when you look at the axial view taken halfway down the length of the incisal root, you notice that there's not actually enough alveolar housing to fit the 4 incisors in. So where you might look at that case and go, well, let me do a little IPR 3 to 3 to see if I can get a little better positioning of those incisors, that will make the situation worse. So I suppose you could IPR the lateral segments, but then you're compromising a nice class 1 relationship this patient has. So the cases that look very, very simple.
Hey, Jeff.
Yes.
This is Rob. We have a couple of people that are having some issues seeing the slides. They can hear you just fine, but they can't see the slides. I don't know if maybe it would be a good idea to just bounce out and come back in.
Okay, let's see. How about now? Can they see it now?
I'm asking the participants, hold on. Good, we're good to go.
Okay, so this case that looks very simple and straightforward from a perspective of a pan-ceph analysis, when you start looking at it from a cone beam CT, becomes more complex because those lower incisors do not fit in the alveolar housing properly. There's not enough room there. IPRing 3 to 3 doesn't get you anywhere. You can't IPR the roots. And I suppose you could IPR the lateral segments and distalize the cuspids, but then you're compromising the nice class 1 relationship that the patient had. This is another case that was referred to us by one of the local periodontists in our community. This patient is an adult patient. The periodontist had finished the periotherapy. And if you look at this case from a pan-ceph perspective, you know, you're pulling out 2 upper buys and you're IPRing the lower anterior teeth. That's pretty straightforward. However, when you look at it from a cone beam CT perspective, you notice right away that the roots of the upper incisors are already dehisced through the palatal cortical plate. And you can see that from both the sagittal and the axial views. So the last thing probably you'd want to do is retract those teeth. But without the benefit of a cone beam CT, how would you know this information? You wouldn't. There's a few things that are just worth mentioning. First of all, I take all my cone beam CTs out of occlusion. I'm not trying to reproduce a cephalometric X-ray, okay? I really could care less what the lower incisor to the mandibular plane angle is because I can visualize the alveolar housing and I need the root of that lower incisor to properly fit within that alveolar housing as best as possible. So if the alveolar housing projects at 120 degrees from the mandibular plane, I'm not setting the lower incisor at 93 degrees. I'm setting the lower incisor at somewhere where closer to 120. When you ask the orthodontist, you know, is cone beam CT going to replace cephalometrics in the future? Most all of them will say yes. But if you ask, you know, what is it that makes cone beam CT unique and why is it going to replace cephalometrics in the future, you get all different answers from the 3D reconstruction, because you can spin it around and you get a better perspective of what's going on. You can look at supernumerary teeth better that are hidden behind the central incisors. You can look at ectopic and impacted teeth and design a mechanical plan to bring them into place better. You can look at the temporomandibular joint from all 3 planes of space. You can look at pathology. You can look at the sinuses. You can more properly parallel your roots. And of course, there's the airway crowd. One of the most undervalued uses of cone beam CT is to look at our early mixed dentition patients and look for things like collisions and do a proper space analysis. Because with cone beam, you can take actual measurements of the unerupted teeth. And if you can avoid the eruption of a potential ectopically erupted tooth, I think that patient long-term is going to be better. So when you do the space analysis, now I'm showing you on the 3D reconstruction because it's just you know, easier to show you here, but you really take the measurements on the individual slices. Once a tooth erupts ectopically, that ectopic tooth is always going to have compromised bone support to the root. If you can avoid that and allow the tooth to erupt right through the center of the alveolar trough, that tooth has a better shot for survival long-term. And I think the one thing that cone beam does better than anything else, or there are several things it does better than anything else, but one of the things that, you know, you don't hear too many people talking about is to take a cone beam on our early mixed dentition patients, do a space analysis, and then come up with an appropriate strategy for that. But what is it really that is unique about cone beam that is not available from any other radiological source? Well, for the very first time, orthodontists can look at the limitations of orthodontic tooth movement on individual teeth. In other words, we can look at the root, we can look at the alveolar housing that supports that root, and we can get an idea of how much we can move that tooth. Now, generally, we're looking at the lower incisors because they have the smallest housings. Also, you notice I'm showing you a sagittal view. That's the view that most orthodontists are comfortable with because it most resembles a cephalometric X-ray. But when we talk about anterior teeth, both upper and lower anterior teeth, we're constantly looking between the sagittal and the axial views to determine, whether that tooth is supported well by the alveolar housing. Now, if you're an orthodontist and you believe that you have some kind of special bracket and wire system that produces a light physiological force, and the bone modifies as you expand, and therefore you never need to extract teeth, I'm sorry, but that simply is not the case. I don't know how to be nice about it. There is plenty of documentation that says that doesn't happen. You push the tooth through the cortical plate, you're going to get dehiscence and penetration. One of the analogies you hear that I think makes no sense at all, but you hear it quite often, is that this is the exact quote, a slow growing cyst can dramatically expand the dense buccal and lingual cortical plates. So if that happens, so can a tooth as you expand it lightly with a light physiological force. Well, maybe I was sleeping in dental school that day, but I wasn't aware that a cyst has a periodontal ligament. But I think really the most common sense contradiction to this idea that you can use a light physiological force and therefore you never need to extract teeth because the bone modifies as the arch is expanded. The bone modifies, it's called dehiscence, is an ectopically erupted tooth. When you have an ectopically erupted tooth that erupts outside of the alveolar trough, that tooth is never going to have the same bone support around it as a tooth that erupts in the middle of the trough. I mean, everybody knows that. It's common sense. So if Mother Nature, in its eruption force, which favors bone coverage, cannot properly cover the root of a tooth that's erupted ectopically, I think it's the epitome of arrogance to claim that your mechanical system can do that. Okay, you can't have a discussion about cone beam CT and orthodontics without discussing the reliability of cone beam. You hear a lot about the 0.6 millimeters of non-visible bone. And what is the role of the periosteum in all this? This is a study by Cropella and Nervina. You see here that this is actually an excellent study. They took the slices at exactly the same spots. And you can see here how these cases were treated non-extraction with expansion, lateral development arch wires. And you can see the generalized pattern of dehiscence associated with the movement of these teeth. In their conclusion, they say considerable loss of alveolar buccal bone following treatment. And the one thing that you hear, this is the interesting thing about cone beam. You see these things on the cone beam. You see a dehiscence post-treatment that didn't exist before the patient started orthodontics. And orthodontists have been coming up with rationalizations as to what they're seeing in the cone beam CT is not really dehiscence or penetration. They're coming up with all kinds of things where we see the dehiscence and they say, well, there's 2.6 millimeters bone there. And I think we're going to need to discuss that to just kind of lay the groundwork for the rest of the talk. So let's make two assumptions here. First of all, a tooth root that is completely surrounded by bone is going to be healthier than a tooth that has a dehiscence. And a dehisced root is going to be more susceptible to tissue dehiscence at some time in the future. You rarely see the tissue dehiscence happen during orthodontic treatment, but it does occur sometimes. And that orthodontically induced dehiscence and fenestrations are a negative outcome of orthodontic treatment. In other words, it's an undesirable outcome. Now, just to be clear, if you're an orthodontist and you're practicing and you think you're never going to dehiss or fenestrate a root, that's not going to happen. That's not a realistic expectation. We do dehiss and fenestrate roots. It's the magnitude of the dehiscence that makes the difference. When you start seeing, in this photograph here, a washboard type gingival appearance with blanched tissue, then you know you may have dehisced, and that's probably not a good thing. But can fenestration, can cone beam CT, I'm gonna move this out of the way, can cone beam CT evaluate and diagnose dehiscence and fenestration, and why does it matter? So here's a case 22 years post-active orthodontic treatment. Notice she has tissue dehiscence associated with both lower centrals and the lower left lateral incisor. The PAN and the Ceph do not comment on dehiscence and fenestration. It's not a tool for that. The focal trough is too large. For a Ceph, if a tooth is really significantly dehisced, I mean, really pushed out of the alveolar housing, you can sometimes pick it up on a Ceph. But generally speaking, it's not diagnostic for dehiscence and fenestration. If you look at her axial view cone beam CT, you see that the 3 roots that are dehisced from the axial view completely relate to the 3 teeth that have the tissue dehiscence. You also notice that the magnitude of the tissue dehiscence relates to the magnitude of the root dehiscence in the axial view X-ray. Now you might look at that and say, well, they're brushing too hard. But look at the rest of the mouth. There's no other tissue dehiscence associated with any other area of their mouths other than the 3 teeth that have the root dehiscence that's visible on the cone beam CT. Now, whether the tissue dehiscence occurs or not, or the tissue is completely intact, it looks identical on the cone beam CT. You can't diagnose tissue dehiscence by just looking at the cone beam CT. They look identical. We all know from histology that you get osteoclastic activity on the compression side of the root as you put a force on the tooth, and you have osteoblastic activity on the tension side. And that's fine as long as you move the tooth through the alveolar housing or between the guardrails. That's how we move teeth. The discussion in orthodontics comes in when we start looking at the movement buccal or lingually. So as the leading edge of that root is moved, the leading edge is under compression. The compression triggers osteoclastic activity, and it's the osteoclastic activity that, let's see if I can move this out of the way, that causes the dehiscence or fenestration. And where does the osteoblastic activity come from as you push the tooth through the buccal lingual cortical plate? You know, it's kind of, I think it's a fair question. If you're going to say your system uses a light physiological force, then you need to explain how that mechanism works to keep bone around that tooth. This is a study by Morales et al. And this is one of, several studies that are starting to use the cone beam CT to look at the consequences of non-extraction treatment. So here, if you look, he says non-extraction alignment with self-ligating brackets led to arch expansion associated with tipping of teeth. Expansion related to alignment resulted in horizontal and vertical bone loss at the incisors and mesiobuccal root of the first molars. Thinner tissue biotypes and more severe crowding before treatment increased the risk for buccal bone loss. Well, that makes sense. The more crowding, the more expansion you need to decrowd the arch. The more expansion, the more dehiscence and bone loss you're likely to get. One of the orthodontists in our group is married to a periodontist, and she attended the 2016 Periodontal Conference that was held in San Diego. This is similar to our annual session. If you look at the slide, it says, does alveolar bone bend? You know, there's a concept in orthodontics that when you flare teeth, that the alveolar housing flexes or bends with the tooth. For example, if you were using class 2 elastics and the lower incisors flare forward, there's a concept that the alveolar housing bent or flexed with the position of the new position of the lower incisors. That is an artifact of cephalometrics. You can see from the photos here where they're showing all the root dehiscence that the answer to the question, does alveolar bone bend, is clearly no. This is an adult patient that came in for treatment. You can kind of get an idea what her malocclusion looks like and her alveolar housings. You know, how much can you retract those upper teeth before you pull them out of the alveolar housing? But you wouldn't know that by you looking at a cephalometric x-ray. So in this particular case, we told her, you know, first, you know, we asked her if she would consider getting a pre-orthodontic arch augmentation where they graft bone to give us a little more real estate to retract and upright the teeth. She didn't want to do that. We said, well, what we'll do is the lower we'll try to close a little bit, but we'll plan to put a 5th incisor in there. And on the upper, we'll retract, take periodic cone beam CTs, and at some point we'll have to stop. So here she is. You can see on the left is the original position of her tooth pre-treatment. A year later, we have it a little bit retracted, and then we stopped a year later, and you see clearly that the tooth moved, the alveolar housing stayed where it was. Now, I probably retracted her a little bit more than I should have, but that's what, you know, that's where we stopped. Now, when you're looking at cone beam, you have to be mindful of where the slice is coming from. So if someone says, look, that tooth has plenty of bone, you need to look at both the axial and sagittal views and see where the slice is taken from. So in a case like this, where you have a fenestrated root, if you slice through that root, you're going to get an axial view that looks like this. That looks pretty scary. But if you go down a little bit and slice closer to the CEJ, there's a nice thick alveolar housing there. So, you know, this cone beam is not a static evaluation like a Ceph. It's dynamic. You're constantly slicing through different portions of the tooth from different planes of space. So how accurate is cone beam CT in measuring bone? Well, there's plenty of documentation now in the refereed scientific literature. And I think if you look at this literature, you can basically break it down into two categories. How accurate is it in taking measurements? And how accurate is it in diagnosing dehiscence and fenestration? And for orthodontics, I think it's also important, although this is not part of our literature, is how accurate is cone beam in identifying and visualizing the anatomy of the alveolar housing? Because for orthodontists, this is an important consideration. So if you would have attended the 2020 AAO annual session that was held virtually, you may have noticed that anytime someone showed a cone beam CT with a dehiscence, that they assumed that there was 0.6 millimeters of bone surrounding the dehisced root. And you heard them say something such as, well, studies show that there's 0.6 millimeters of non-visible bone, so this tooth is fine. That's not what it means. It means there's plus or minus 0.6 millimeters of bone. The margin of error in measuring the thickness of the bone is 0.6 millimeters. So when you see a root that's dehisced like this, it doesn't mean that there's 0.6 millimeters completely surrounding that root. That's not what that means. It means that if you measure where you can see the end of the bone, there might be 0.6 millimeters plus or minus. It's really not that relevant to what we do as orthodontists. In terms of the anatomy of the alveolar housings, I don't think anybody has a problem with that The cone beam CT accurately represents what the alveolar housing looks like in size and shape and projection. This unfortunately was a 19-year-old girl that was killed tragically in an automobile accident. On the right is the dry skull section from the autopsy result, and on the left is the cone beam CT of that dry skull section. And you can look at both of those, and there's no question it accurately represents what's there. When it comes to dehiscence and penetration, and you look at the studies, you have to be mindful that these studies were done on naturally occurring dehiscence and penetration. These naturally occurring dehiscence and penetrations are usually, minor in nature. If you're looking here at this, this fenestration of this root, this is minor. This is still a healthy functional tooth. And so are these, with the exception of ectopically erupted teeth. Ectopically erupted teeth are going to have dehiscence and fenestration of a much more significant magnitude. So when you take a look at an axial view, this is a pre-treatment, think about an 11 or 12-year-old patient. And you look and you say, where are the dehiscence and fenestration? You can look and say, well, it looks like there's a break in the bone here, maybe here and here. So both cuspids in the lower right central incisor may be slightly dehisced. Or maybe there's an additional 0.6 millimeters there. It really doesn't matter that much, because what this tells you is that you probably don't want to use mechanics that are going to further expand the intercuspid width, because those cuspids, whether there's 0.6 millimeters there or not, are most likely at their limit, and you don't want to push them out any further. But when we talk about orthodontically induced dehiscence, we're talking about dehiscence of a much more significant magnitude. These are dehiscence where you have a third of the root or half or even more of the root outside of the alveolar housing. These are mechanical dehiscence caused by orthodontic treatment. So when you talk about that 0.6 millimeters, plus or minus 0.6 millimeter error, how relevant is it to a case like this? It's probably not relevant at all, because the area that may or may not be 0.6 millimeters more or less doesn't mean the root's covered. It means there might be an extra 0.6 millimeters there. So what? That tooth is outside of the alveolar housing, and it's not a good tooth for long-term prognosis. So how relevant is the 0.6 millimeters of non-visible bone? Well, here's a simulation of dehiscence, okay? It's level 1, 2, 3, 4, and 5 plus. A stands for axial view, 2 means the middle third of the root. On the level 1, that's the case we just looked at. Whether there's extra 0.6 millimeters of bone there doesn't mean anything. That just tells you, I don't want to over-expand that intercuspid width. Level 3, 4, and 5 plus, I mean, if it's pre-treatment, you may want to consider removing the tooth if that's what your plan is. If it's post-treatment, that's probably not a good thing. For the level 2, if it's pre-treatment, you certainly don't want to expand anymore. And if it's post-treatment, if there's a 0.6 millimeters of extra bone around the tooth, great. But what does it change? It doesn't change much. So here's a study by Sun. If there was a severe dehiscence on the cone beam CT image, there was probably a true dehiscence. This is the category where orthodontically induced dehiscence falls in. So when you look at something like this pre-treatment, what it tells you is don't expand the intercuspid width any more than it is. Those teeth are already at the limit. Without seeing a cone beam CT and just using a pan and ceph, you're not even mindful of these things. One of my mentors was Dr. Schaefer, and when he saw something like this, he would say, they're actually proud of this. This is a case from Embrace. And they were, I actually can't believe they showed it. So here we have two ectopically erupted cuspids. You look, if you can see it closely, it looks like there's composite fillings at the CEJ of those cuspids. They're ectopically erupted cuspids. So the solution here is to expand the lower incisors so they align with the ectopically erupted teeth. I mean, and you know, in whose world does that make any sense? Now they do say that they used some IPR there. I mean, I don't believe you can IPR your way out of that case. But you know, compare it to an ectopically erupted tooth, where the root is significantly dehisced through the cortical plate, and now you're bringing the incisors to align with a tooth that's ectopic. I mean, you know, that's not behaving like an orthodontist, in my opinion. So if we go back to this case that I showed you in the very beginning, is this a well-treated case? Well, look at the tissue associated with the lower anterior teeth. You could see the blanching, you could see the washboard gingival appearance. If you looked at this from a cone beam CT perspective, I think you would see a generalized pattern of dehiscence that comports with the shape and size of the arch wires that are used. This is a case that orthodontist shared with me. This is a case where he used one of those systems that claims to use a light physiological force, so there's no reason to ever extract teeth. So this is what the patient started with, and here is what the patient finished with. And if you do the measurements, they expanded the intercuspid width over 11 millimeters. Okay, 3 years after the case is completed, they took a cone beam CT, and you can see how all those teeth are generalized pattern of dehiscence associated with lower first bicuspid to first bicuspid compared to what would be, you know, that untreated 12 or 11-year-old that came in. So when we look back at Capella and Nervina's study, where they showed the generalized pattern of dehiscence, the dehiscence pattern comports with these broad-formed arch wires. And when you compare it to that case that's 22 years post-treatment, you see that all these dehiscence, they look pretty much the same radiographically, but some have tissue dehiscence and some don't. So I think it's, you know, do all these tissues, if you dehisce, does the tissue always dehisce as well? You know, who knows? I mean, you know, you got people that smoke 4 packs a day and live to 100, and you got people that die when they're 35 from smoking. So there's other factors, the quality of the tissue, thicker gingival biotypes probably withstand better than the thinner gingival biotypes. But certainly, if you can try to minimize the dehiscence as part of your orthodontic plan, the patient's going to be better off. I don't think anybody's going to argue that. And that's, in my humble opinion, that is behaving like an orthodontic specialist. The other thing you hear from orthodontists that look at these cone beams and try to figure out a way that they're not seeing dehiscence and fenestration is they'll say something like, well, I'll give you that there's dehiscence there, but as long as the periosteum's intact, then there's really no problem because bone will fill in over time. And that's actually a true statement. The question is, how do you know if the periosteum is really intact? So this case is an example of, I think, where this argument comes from. This is a case that I treated, and we extracted 2 upper bicuspids and retracted those upper incisors about 5 to 7 millimeters. Okay, this is the immediate post-treatment cone beam CT, and you can see it appears that the root has been dehisced through the palatal cortical plate. She comes back 32 months later, and the same tooth, same slice angle, it looks like the bone filled in nicely. So this is kind of what you look at and go, oh, well, that's fine. You can dehisce, but bone fills in because the periosteum is still intact. Well, you have to know where these slices are coming from and where at what level. So this is a, kind of a mission critical thing for cone beam CT. So when you look at this case, and then you see the sagittal view, the sagittal view by itself doesn't mean anything. And I'll explain why. We're just tied to that sagittal view as orthodontists because that's what we're used to. So this is his case. It started in 2013. Back in 2013, we were still taking pans and ceph. We had cone beam, but we would only use the cone beam when we thought it would make a difference in the treatment planning of the case. Now, obviously, we take cone beam on everybody. This is her occlusion. She has a slight bolt in. Our plan was to use the molar space to decrowd the lower arch and balance it with the extraction of 2 upper first bicuspids. Today, I would treat this case differently. Now, notice on the occlusal photograph of the lower that you see how if you can see it, the lower edentulous space appears to have an hourglass kind of shape to it, okay? When you take a look at the ceph, and especially the pan gives you the idea that there's plenty of bone there to decrowd that lower arch. So here she is, 19 months later. She's being treated with incognito linguals on the top and traditional braces on the lower, and she finishes after 26 months. We take a cone beam CT, and we look at the upper incisor, and we're like, what is going on here? We over retracted these teeth. And just from a comparison standpoint, the cephalometric x-ray doesn't even get you into this conversation. You sometimes can see a root that's dehisced from the facial if it has a significant dehiscence, but on the lingual, you can't see it because it's covered up by other structures. She comes back 32 months later. We take another cone beam CT and we take a slice at the same exact spot, and you see it looks like the bone filled in. So what actually happened? Was there true dehiscence? Was there immature bone? If you look at the axial view, this is immediate post-active orthodontic treatment. You slice through the center of the tooth, it produces a sagittal view that looks like that. That axial view is determined by the slice of the sagittal view. So these two views kind of go together in terms of the anterior teeth. The coronal view is really used to align up the teeth, but it becomes more relevant when you get to the lateral segments. But for the anterior teeth, once the teeth are aligned, meaning you're taking slices perpendicular or parallel to the long axis, then you're really kind of jumping between the axial and the sagittal views. When you look at the case 32 months later, we slice and we take the same slice and take a look. And when you compare the axial views, you go, wait a second. I don't know if you can see this, but there is bone behind those upper central incisors. It's just a little cloudy because it's a little bit immature bone. So the only difference really is that you notice that in the 32 months post-treatment active orthodontic slide, there's a more defined cortical plate. With cone beam, unlike pan and ceph, we could just take a progress X radiograph anytime you want. To really evaluate the bone, you need that root to come to its final resting position and wait 6 months before you take the cone beam. If you took a cone beam 6 months after active orthodontic treatment, it would look the same as a 32-month one. So what happens is, if we take the lower right lateral incisor and stick a tooth in there, you saw that we have a 3-wall defect there. If we slice through that root, that produces a sagittal view that looks like that. Now, depending on the cone beam CT manufacturer, that slice thickness defaults at anywhere from between 0.2 millimeters and 0.5 millimeters. So the sagittal view that's produced only is 0.5 millimeters thick, more or less. It doesn't tell you how wide that defect is as long as that defect is wider than the 0.5 millimeters. So if that defect, looking at the sagittal view alone, you don't know if that defect is 0.6 millimeters or 6 millimeters. There's no way of telling. And that's why you need the axial view to confirm the actual anatomy of the defect. So in the case I just showed you, whether that was immature bone or a little slight dehiscence in that leading edge of the lingual part of the root, when we slice through that, that 0.5 millimeter slice produces a sagittal view that looks like this. And without the axial view to go along with it, it really doesn't mean that much. And that's why in this particular case, there was probably no dehiscence. It was probably just immature bone. But that's where this argument comes from, where it says, well, if the periosteum is intact, look at these dehisced teeth, because they're only looking at the sagittal view. Compared to the woman I showed you earlier, this is a true dehiscence. Okay, so getting back to the question, how do we know if the periosteum is intact or not? Well, you don't. You only know after the fact. If the root dehisces the tissue, it's always a clean root. It's not going to be a root with a layer of bone on it. It's going to be a clean root. So there obviously was no periosteum. But the question really for orthodontists isn't how do we know if the periosteum is intact or not? It's how far can we dehisce the root before there's a problem with the periosteum? How far can we orthodontically maneuver that tooth outside of the alveolar housing before the periosteum is no longer intact? And, clearly we can do it a little bit and it doesn't seem to affect the health of the tooth or the gingiva. But when you start looking at these cases where half the root is dehisced through the cortical plate, I mean, that is not a good thing. Adaptive resorption and retreatments kind of go together. Let's go back to this case we just spent all that time with. If we retracted the upper incisors 5 to 7 millimeters, what happened to the facial bone that was there when she started? In other words, there should be an extra 5 to 7 millimeters of bone facial to that retracted root. But it's not there. It's not there because it adaptively resorbed to comport with the orthodontically repositioned root. And that doesn't matter whether you go buccally or lingually. You move the root, the bone adaptively resorbs to comport with the orthodontically repositioned root. Sarkaya showed it in 2002. He called it, instead of calling it dehiscence, he calls it lingual plate invaded and the labial plate remodels. So there are consequences to poor orthodontic treatment planning. So if you're going to treat a case and overexpand the arch and say, let me try this and see if it works out, and if it doesn't, then I will retreat the case. Well, you may be retreating the case with a very diminished alveolar housing. And it seems the thinner the cortical plates are, the faster the adaptive resorption occurs. Now, this case was sent by an orthodontist in Florida. It wasn't his case. I don't know where he got it. These are the only 2 images he sent. I assume this was on one of the orthodontic Facebook groups. But you can tell quite a bit about this case. First of all, you can see the attachments. So obviously they're being treated with aligners. They don't have proper alignment of the lower incisors yet. You see the blanching of the tissue associated with 5 of the 6 anterior teeth. And you see the frenum involvement on the lower right central. I will assume that's the sagittal view cone beam CT slide. But also, this patient has probably been in aligner treatment for an excessive amount of time because the adaptive resorption process has already occurred. Now, to try to reposition that root back into the alveolar housing would be difficult, if not impossible. One thing you won't see on a post-treatment cone beam CT, post-treatment, this is a case that's being set up by Breus. Breus sets up their cases. You have the ability to do a cone beam CT overlay, so you can see the position of where the roots end up virtually. And then the Breus archwire then moves the teeth to that position. Now, I'm not suggesting just because you see it set up virtually, that is exactly what's going to happen. Although I believe it's pretty close. But it gives you an idea of what happens to the bone. Now, the bone modeling here is static. So this case, we extracted 2 lower buys and retracted by uprighting the lower incisors. What you'll never see in a post-treatment cone beam CT is the excess bone that was there when you started, from both a sagittal view, and look at this excess bone here on the axial view. So this bone was there when those teeth were forward. Now the teeth were retracted. If you take a cone beam post-treatment, you're not going to see this alveolar bone there. It disappears. The same thing happens when you expand the arch. The lingual bone adaptively resorbs to comport with the repositioned roots. Another thing you won't see is when you see a dehisced root from a sagittal view, you never will see something that looks like that with bone coverage on the facial of that root. Okay, so this is really the meat and potatoes of the talk. You know, what is the role of the alveolar housing? Now, we all agree that all men are created equal in God's eyes, but bone is not. Bone varies not only between different individuals, it can vary in different segments of the same individual's arch. But without cone beam CT, you're never going to be able to visualize it. These are 2 lower incisors. The housing on the left is a lot better and easier to work with than the housing on the right. And when we look at upper teeth, we have the same thing. Both these patients need retraction of the upper teeth. The patient on the right, no problem. The patient on the left, that's a much tighter alveolar housing that doesn't have the same tolerances as the patient on the right. The cephalometric X-ray does not consider the anatomy of the alveolar housing. Here's a retreatment case. Look at the upper lateral incisor. Should that play a role in our orthodontics, or should we just ignore it? Should we treat that patient the same as the patient on the right with a much more robust alveolar housing? How would this look on a pan and cephalometric X-ray? You wouldn't even know it because the focal troughs are too wide to properly diagnose the position of those teeth and the support for those teeth. Here's another case. This patient was treated, she came into our office for the 3rd time. We didn't treat the first 2 times. First time she had 4 buys taken out. The second time she had a lower right central incisor removed. Take a look at her lower arch. I mean, that looks like a fairly simple, straightforward case. Pan and Ceph do not comment on really what's going on here. You take a cone beam CT and you slice through that interproximal area between the lower left central and the lower right lateral incisor, notice that the alveolar housing associated with that edentulous area, or where the tooth was extracted, is only 1.5 millimeters wide. You're not going to be able to push that root through that hourglass. It's not going to fit. So when you look at a case like this, and you look at the angulations of the inclinations of the angulations of the incisors, are you going to want to upright all those roots? You know, and then, you know, how relevant is the 0.6 millimeters of non-visible bone? Can I give it? I'll give you the extra 0.6 millimeters. 2 millimeters is not going to make any difference in this case, in that edentulous space. And you're never going to be able to correct the dark triangle without some kind of surgical procedure that grafts bone in that area. So if they're not willing to do pre-orthodontic arch augmentation, then you're probably going to need to finish this case with that lower left central incisor with that kind of angulation. Here's another case. This is an 11-year-old boy. Notice the lower right central incisor. That root is already dehisced. That's probably a level 2 or level 3 dehiscence. Alignment of that root is going to cause further dehiscence of that of that root. It just won't fit in the housing. Now, you could do 10 of these and you won't have, any immediate problem with the tissue. Long term, it might be an issue. This young man had a kind of thin tissue biotype, but he's 2 millimeters short in alveolar housing and he's already dehisced. So we saw that. We told them to see the periodontist for the grafting. They wouldn't do it. We put the brackets on, took a chance, and the tissue popped. Generally, when the tissue recedes like this, the patients say, woke up one morning and the tissue wasn't there. We took the wires out, waiting for him to go see the periodontist, still without a lower wire. What do you do in a case like this? You can't really do IPR. You can't extract the lower incisor. You can't extract 2 lower bis. There's not a whole lot of that you can do to try to better this situation other than some kind of periosurgery. I'm going to walk through a few cases and you kind of get our, what we do in terms of process. I'm trying to give you an idea of comparing the pan and the Ceph diagnosis to cone beam CT. This case here, I put in here because I believe most orthodontists, or at least I hope most orthodontists would extract on a case like this. Here's the recreated pan and Ceph. And by the way, when you see all this crowding in the pan and Ceph become less effective because not only do you have the wide focal trough, but you also have teeth overlapping each other. How do you trace that out on a Ceph? So if we look at this particular case, this would be maybe a 4-bi extraction case. Strategic extraction patterns aren't only about anchorage, they're also about which teeth to extract. For example, if you have a case that has, you're planning 4 bicuspid extractions and that patient has a bombed out upper second bicuspid, you're probably going to extract the upper second bicuspid because you can recognize that that tooth is compromised. Well, with cone beam, you can look at the root and see if the root has compromised bone support. So in this particular case, we knew we were taking out 2 upper bis. The lower left central was significantly dehisced. There was already periapical pathology associated with that tooth. I get an idea. And so that was kind of a no-brainer. Instead of taking the lower left bi, we took out that lower left central. The question really came in as to which tooth on the lower right we would take out. Should we take out the lower first bi, or should we take out the lower cuspid? Okay, so this is the first bi, and here's the cuspid. So when you compare the two, you notice that the first bi is well centered within the alveolar bone. The cuspid, the lower right cuspid, has a class 3 dehiscence. It's a higher level of visualization. And just like you would probably pull a second bicuspid that you can visualize a lot of damage, this is a compromised tooth. The defect moves with the tooth orthodontically. So in this case, we took out the lower right cuspid. When it comes to
Jeff, I've got a question here that came through.
Okay.
This one's, are there any methods to prevent or slow down, if any, to reduce the amount of reabsorbed bone in the adaptive area? If we can maintain constant compressive forces on the adapted resorbed area, would the resorption not be as severe, or at least would we be able to reduce the rate of resorption?
I'm not sure. I know that I don't have that. I can't comment on that. I don't know the answer. I'm not sure when you mean if you move the tooth outside of the alveolar housing, the alveolar housing will adaptively resorb to comport with the position of that orthodontically repositioned root. To slow it down, I mean, you can do, surgically facilitate orthodontic treatment to add bone if you know you're moving the tooth in that direction. But I haven't seen anything or read anything about slowing down the adaptive resorption process. Think about a tooth that's extracted. If you extract the lower incisor and just leave it there, that alveolar housing disappears over time. So maybe sometimes you can put, like sometimes we'll go and if we order a lower incisor extraction, we'll have the surgeon add bone into the socket, kind of slow down the resorption, the adaptive resorption, because the adaptive resorption can occur in the extraction space as well as, you know, the rest of the alveolar housing. But I'm not sure I really have an answer for that. It's a good question. I just don't know the answer. Keep going, or you want me to?
No, that's it. They said thank you. That's good. Thank you.
Okay. So when it comes to comparing a ceph and a pan, you know, we have to, I believe we have to stop trying to apply cephalometric standards to a cone beam CT. I think it takes us in the wrong direction. Currently, there are two camps that are kind of cone beam CT oriented dentist. One camp says, you know, we're trying to get a cephalometric analysis out of the cone beam CT so we can do a 3D cephalometric analysis. And the other camp, which I'm a member, says, forget it. I don't care what the lower incisor to the mandibular plane angle is. I can visualize directly what the anatomy of the alveolar housing is. So, you know, what do I care what the lower incisor to the mandibular plane angle is? It's not relevant anymore because I can visualize the actual anatomy of the alveolar housing in size and shape and volume. So I think that, you know, I know people don't like to hear this, but I think the cephalometric analysis is outdated, obsolete information. It doesn't really provide anything that's of any significance, and it gets orthodontists in trouble more than it helps them, especially now that we have a cone beam CT. You know, certainly Andrew's 6 keys of normal occlusion, he did not have the benefit of cone beam CT, but when it comes to torque or crown inclination, you know, before you start torquing teeth, to bring it to some cephalometric norm, you better know what the anatomy of that alveolar housing is. So in a case like this is a 13-year-old boy. He's got, you know, bimaxillary protrusion. You can see, you know, it's a slight bolt discrepancy. I mean, everybody's treating this case the same way if they have a ceph pan analysis. They're basically going to retract and upright the incisors to bring him to some kind of cephalometric norm. And here he is, you know, just the 3D reconstruction. But look at the alveolar housing associated with that upper incisor. Do you really want to retract and upright that so it comports with a cephalometric norm? I don't think so. I think it's the wrong direction to go as an orthodontist. So I asked the fellows at Breas to simulate treatment on this case. This is the 3D reconstruction that they can now simulate treatment on. So they take the STL file from the digital scan and they take the cone beam CT and they overlay them. So when you simulate treatment virtually, you see the position of the root. So they simulated this case 2 ways. The first way, using Andrew's 6 keys of normal occlusion. And you can see by putting it to average torques, you can see the fenestration associated with those roots. This is a different patient, and it probably looks something like that. Now, is that going to be a long-term clinical problem? I actually don't think so. I think that's a reasonable outcome for orthodontic treatment. But I do think that the lower anterior teeth on the right side got pushed out of the alveolar housing significantly, and that could be a problem. Slight minor adjustments to the torque settings produce a result that looks like this. I mean, it's minor. And I think when you have cases that have these very narrow, small alveolar housings, there's no better argument that as orthodontic specialists, we need customized appliances that can predictively move those teeth in a precise position. So when you compare the 2 results, now, like I say, I don't think the upper is really that much of a problem, but if it was you or one of your loved ones, you're certainly going to want the result on the right versus the left. And these are minor changes to the setup that produce those results. Here's another case, very, very similar. Bolt discrepancy, bimaxillary protruded. Here's his 3D reconstruction. Look at his alveolar housing. This patient has a larger alveolar housing. We probably don't need the expense of a customized appliance to treat this case, because traditional orthodontics could treat this case well.
Jeff, got another question.
Yeah.
So the question is there a superimposition technique on 3D imaging? In other words, is there a 3D technique for the type of outcome assessments where you do cephalometric superimpositions to differentiate between growth and treatment changes?
Yes, there is. You can do not only the individual slices, but you can do the 3D reconstruction, and you can superimpose the 3Ds. You can also separate the mandible from the maxilla, and that's one of the reasons why some orthodontists take the cone beams out of occlusion, because for that very reason, you can manipulate it more. You're not getting the interference from the overlap of the clinical crowns of the teeth. So the answer is yes.
Very good, thank you.
Okay, if you compare this patient on the right, has a much nicer alveolar.
Wait, one more thing. Follow-up question is, what are the stable structures used for the superimposition?
Okay, it's not a cephalometric X-ray, first of all. So you can superimpose on the cranial base, but you can do it in a 3D way. So it's a much more accurate superimposition. Okay. So you can take what you do, depending on the software you're using, basically you're taking points. You're taking stable points. If you want to use, Nasion, or you want to use Stella, you can take those points, but you could use you're taking more than 2 points. You're taking points so you can superimpose in 3D. I can't think of the term for it. Maybe someone could help me with that. But you're superimposing 3D structures, not 2D structures. So when you superimpose a cephalometric X-ray and you're superimposing over, Frankfurt horizontal plane or Stella or Nasion, you're assuming that that's the center of the structure. With cone beam, you're not guessing anything. You can actually look at it and pick the points, and you're getting a true 3D superimposition. When you superimpose a cephalometric X-ray, like I said, cephalometric X-rays do not comment on changes to the intercuspid width. So if you decrowd the arch by expanding the lower intercanine width, the changes to the lower incisors as measured by a cephalometric X-ray are going to look minimal, where a cone beam would show you exactly what happened.
Okay, very good, thank you.
Okay, so if you look at these two patients, I think the patient on the left with the thinner alveolar housing, these patients probably should, depending on what you're doing to move the teeth, these patients, we consider using a customized appliance that is set up on the cone beam CT versus the patient on the right. You can get away with more because it's a wider alveolar housing. When you ignore the alveolar housings and just treat the cases to cephalometric norms, this is a case right off the global gallery. 4 bicuspids were extracted. And just to mention that this discussion about keeping the roots within the alveolar housing, it's not a discussion about extraction versus non-extraction. It's really a discussion about what treatment strategy keeps the root centered within the alveolar housing the best. Sometimes it's impossible, but at least minimizing the magnitude of dehiscence is important. Notice the finished photograph on the right. You see the blanched tissue associated not only with the upper roots, but the lower roots as well. And when you look at the pan, that doesn't tell you much, but these are high quality cephs. And when you look at the ceph, you can see that the roots are pushed out of the alveolar bone. Is this a good treatment outcome? I don't believe it is. I think this is a treatment outcome that completely ignores the alveolar housing. And if you look at the pre-treatment cephalometric X-ray, you can see that this patient has like an, kind of a little bit unusual alveolar housing to begin with. But if you're not mindful of it, then you're going to just set the teeth to average torques. And that's what, I guess people that just do the aligners and just click the approve button and they don't think twice about it. When I first saw this inset slice image, I thought it was unusual. And turns out it's not really all that unusual in our profession. This is a case that was just posted on Orthodontic Pearls just recently. It was a transfer case. You can see from the Panorex, this patient's wearing torquing auxiliaries. So they were trying to torque these teeth. The patient disappeared for 5 years and then ended up in another orthodontist's office, and he posted it on Facebook. You look at the Panorex and it looks fine. And you look at the cephalometric x-ray, and if you were to measure the incisors really don't even look that bad. They're actually in a good relationship to each other and to the apical basis. But when you look at it closer, you see that the roots are completely pushed out of the alveolar housing. And when you look at the clinical photos, although these teeth are not, not really, retroclined, or the roots are not in a very good position. And notice also that the tissue has not dehisced yet. After 5 years, before you touch this case, you definitely would need a cone beam, because you don't know what the adaptive resorption process on the lingual of these incisors is. You don't know if there's any alveolar housing back there or not to reposition those roots. And if they're not, I'm not sure what you can do here. Okay, so I'm going to finish by just walking through a case. When you have thin housings, I think there's an argument for a customized appliance that incorporates the cone beam CT in the virtual treatment. Unlike most of the aligner companies, when you set up those cases, you're really only looking at clinical crowns. As an orthodontist, we have a little better insight into it, but there is technology available that allows for the visualization of the repositioned tooth as well as the root and the alveolar housing. So this is an adult male patient. You can see what his malocclusion looks like. You see he has a lingually locked upper right lateral incisor. There's his digital scans. He's class 3 skeletal, and he is a class 1 dental. When you look at his 3D reconstruction, you notice he has clefting associated with both upper lateral incisors. And when you look at the axial view, you see that he has this called kind of like bat wing appearance, because the alveolar housing, comports usually with the position of the teeth. So in this case, if you were to expand, that means you're expanding the cuspids, the centrals. The lateral incisors then have to come much further forward to align with the expanded centrals and cuspids. So you see the clefting associated with those laterals. If you're going to try a non-extraction approach, you could potentially do damage. So I don't believe this patient has the alveolar anatomy for expansion strategy. And that's why you can see it looks like a bat. So if we look at the upper right central, if you're going to extract versus expand, the upper right central is going to be retracted and uprighted. Okay. If you look at the upper right lateral, the lateral has a thinner, smaller alveolar housing. So when you compare these things, which tooth has more maneuverability? Well, the central incisor has more maneuverability. You can retract and upright it. So here's the virtual setup using the Breus model. Notice there's already a dehiscence associated with the upper right cuspid there, because these bone modeling is static. So here we set this case up both ways. We set this case up with a non-extraction IPR approach, And look at the roots of those lateral incisors. They're really significantly pushed through the facial cortical plate, especially the upper right lateral incisor. You know, also the emergence profile of these crowns, you know, I don't think too many people are going to do this non-extraction, but I think it's just an example. And here he is with an extraction approach. So we extracted 4 buys. And, you know, I think cosmetically, certainly extractions look better, but I don't think the non-extraction approach is even reasonable. The idea is to keep the teeth centered within the alveolar housing. And you could see here from a sagittal view, you know, the difference. And of course, I believe the extractions are appropriate in this case, and that's what we're doing. Now, why this case worked, here's superposition. You can see that this case worked out well because the upper right lateral incisor didn't need to move very much. It had the thinnest housing. So, you know, if we could keep that tooth in place, I think the case worked out better. When we look at the lower, I mean, we did upright those lower incisors quite a bit to get them to fit under the upper incisors. Obviously, this ideally it would have been a surgical case, but he didn't want to do that. Notice that on the lower, there is some increased dehiscence on the lingual side of those lower incisors. So, I mean, this is a consequence of what we do orthodontically. You know, the idea is to minimize it. I still believe the extraction plan worked better than the non-extraction plan from both the cosmetic standpoint and keeping the roots within the alveolar housing. Would have been better to do it surgically, but he didn't want to do that. And that's basically all I have. If you need the CE credits for this this talk, please email TJ Ross. TJ works at our office, and he will get you the certificates. His email is tjross@orthodonticassociates.com. If you have any questions or comments, I'd love to hear from you. And I'll let Rob take care of that.
Yeah, let me remove everybody from the lockdown if I can. Okay, you guys should be able to ask a question if you have one. Any additional questions from anyone?
I think you may have muted everybody. If anyone has a question, you can just unmute your microphone and ask.
Yeah, actually I've got it. You can just unmute your microphone now. You're allowed to. Before you were locked, but now you're not. Sorry, didn't explain that well enough.
Hi, Jeff. Nice presentation.
Thank you.
Eddie, I have a question here for you, if you don't mind. You know, sometimes some moms or patients have unreasonable concerns about radiation, and sometimes they think about CBCT has like a lot more radiation. How would you answer?
Well, I think that most all the manufacturers now have a low dose setting on the cone beam CT. So the low dose setting is actually less radiation than the pan and Ceph combined. So, you know, if they ask, we just explain it. We do a low dose setting. Now, the low dose setting doesn't give you as vivid of an image, but it's certainly good enough for what we do orthodontically.
That makes sense. Thank you very much.
Yeah.
Any other questions? Again, all you need to do is hit your unmute, and you should be able to ask the question.
Yes, I have one question. Regarding the regional anatomical superposition on the maxilla and mandible, do you have any structures in which you superimpose on the maxilla and mandible to see the difference?
When I superimpose, I am looking at individual teeth. So if, for example, if I'm looking at the changes of the lower incisors, I'm not trying to reproduce a cephalometric reposition. I'm trying to look at the individual housing. So what I'll superimpose the apical base, and then I can look at the changes that occurred to the position of the lower incisors. So instead of, you're looking at individual teeth for the superimposition. At least that's the way we do it. You can do the 3D, but I don't think it's as valuable as looking at individual teeth, if that makes sense.
Thank you.
Have CBCTs completely replaced pans and lateral cephs for you? And if not, when do you do panos and lateral cephs now?
Well, you can, to answer your question, yes. For me, yes. We don't take a pan or a ceph anymore. You can recreate the pan. You can recreate the cephalometric X-ray from the cone beam CT. So we don't, but I can't tell you the last time I actually looked at a ceph. The only time I look at one was when I'm putting a presentation together, or occasionally there's an insurance company that wants to look at a ceph and a pan. So we'll reproduce the pan and the ceph. But I believe personally, I believe that the cephalometric analysis is completely obsolete. And I know that that doesn't sit well with a lot of orthodontists, but the more you get into cone beam and realize you're looking at individual teeth and the anatomy of the alveolar housings, assuming you don't want to ignore the alveolar housings, then the cephalometric X-ray doesn't comment on the alveolar housing. And that's a vital consideration for orthodontic treatment planning.
I understand. Thank you.
Jeff?
Yep.
I was hoping you could you just speak to what we're seeing from some orthodontists and I guess GPs that are doing orthodontics that believe that they can sort of, if they do early expansion, even on 4 or 5, 6-year-olds, they almost never have to extract if they do that. And even if they don't, they can use tooth-borne expansion type appliances to never have to extract. It's just this whole philosophy of it. I was just wondering if you could speak to it for a minute.
Well, I think when you're talking about, let's just talk about the systems that make claims that they use special forces so that you never need to extract because you can decrowd arches using their appliance. They're just, not only do they not make any sense and they're contradictory to any orthodontic studies, but now you can actually visualize the dehiscence with the cone beam CT. So, and I'm aware that one of the manufacturers used cone beam CT axial views to kind of support their theory that there was enough bone modification that the tooth was still healthy when they expanded the arch. But, nobody really knew what they were looking at back then. And I can tell you that when you get adaptive resorption on, let's say if you expand buccal and you get adaptive resorption on the lingual, at first, when you look at the cone beam CT, the root does look like it's still centered within the alveolar housing. But all you really did was got adaptive resorption on one side and dehiscence on the other. So that company that used the axial view cone beam CTs as proof that their system worked, they've removed all their cone beam CTs from their website, at least the last time I looked. So, I mean, you got to wonder, if that's their main source of proof, how in the world did they not leave those cone beam CTs up on the website that they used to have? The other thing is that when they're using these light forces, people that use that system, they've developed fixes for detailing their cases. So, for example, if they got a rotated lateral incisor, they move the bracket far over to the mesial to get more traction on the when they close the self-ligating bracket. Well, that's not a physiological force anymore. That's a standard orthodontic force. They're moving the bracket to get more rotational force on the tooth. I mean, there's just so many things that, you know, don't really even make sense, and they're completely contradicted by reliable scientific refereed publications in our orthodontic literature. And now we have another body of information that's been studying these things, and all of them point in exactly the same direction, and that is that when you do that, it creates dehiscence and fenestration. Now, whether that dehiscence and fenestration results in tissue dehiscence, that's another discussion.
Have you seen that on the, you know, if someone expands early on and then they want to upright posterior teeth on the lower, I'm talking about a kid who's 7 or 8. It seems to me, I never understood how they rationalized that. Have you looked at CTs, cone beam CTs of lower posterior teeth in those types of situations? It would seem to me that it would take away this idea that you can, you know, you can expand them and then the wider portion of the mandible either comes forward or you can upright posterior teeth and thereby treat these cases non-extraction. I just think, I agree with you. I think it's outrageous. And thanks for a great presentation, by the way.
You're welcome.
So that's what I just can't see how that could actually work. You know.
Yeah, I don't have that much experience. We don't do a lot of phase 1s in our office. So when we see an early treatment, we'll work it up with a cone beam and see sometimes, you know, what to do. Sometimes we'll do serial extractions. You know, if it's a true constriction, paddle constriction, we'll do expanders. But, you know, we don't see the results of the patients that had the phase 1s until later. Okay, so when they've gone through, normally if they do the phase 1s, they end up doing the phase 2 with the practice they started the phase 1 with. So we won't see those patients until they're adults and they look like any other case that relapsed and then need retreatment. But the retreatment cases, they generally have thinner bone to deal with because the teeth have been moved already orthodontically.
Hi there, Dr. Miller. I'd
Yes.
just like to thank you for your presentation. And I'd like to ask, maybe it's a rather technical question, but this concept of adaptive resorption of the bone, is there any literature that shows maybe a rate that it resorbs over time? Or I'm just curious because it's a very...
There was one article that I could find was Sericaya. I mean, I believe you can say it happens definitively because of what you don't see in a post-treatment cone beam CT. But as far as the rates, I don't believe that I've seen anything other than it's only my impression is that the thinner the alveolar housing, the faster it occurs. So in the lower anterior region, that's where the adaptive resorption happens the quickest. And then there's a study by Gerald Nelson, that talks about the alveolar housings related to the skeletal patterns, and that the patients with the dolichocephalic skeletal patterns have the thinnest alveolar housings, and which makes sense because they're usually open. So there's an extension of the alveolar housing. And sometimes when you look at those alveolar housings on those patients, it looks like there's nothing there. It looked like that. I don't know if you remember that case of a 19-year-old girl that was killed in a car accident. You know, you're starting with something like that. So, you know, what do you do about it?
Thank you.
All right. Any other questions? These are good questions, good dialogue here.
Actually, Dr. Miller, I don't know, while I was listening to your presentation, I was thinking about one of my patients. I don't know if you don't mind, I show it for like a minute or two, just show it.
Sure.
How you help.
Rob would have to allows you to share your screen.
Yep.
I think
There you go. It's up. It's up now.
you can see my screen.
I can see it. Can anybody else?
I see it.
Okay.
Yes, we can see it.
Yes.
Awesome. So, yeah, my name is Mehdi Pekar. So I'm the inventor of Breas, and I remember one of the first orthodontists that I talked to about Breas when I came to the US was Dr. Miller, and it was a very great presentation. So just I wanted to show this case here. You see, there's a lot of crowding. This is one of the patients that I am in the middle of treating, and you see here, there's not enough bone. And also on this canine, there's not enough bone. And obviously, you know, it's not the right thing to do the non-extraction for this case. So we decided to do the extraction of lower fours. And let me show you the, so, and you know, based on this Breas planner treatment plan, we could have a treatment plan to make sure that the roots are inside the bone. See here on the lingual, the roots are inside the bone, and on the buccal side, they are also in the bone. And see, this is the design for the Breas, and this is about 10 months later. You see, this is the situation that, yeah, this is the upper arch. I'm not talking about the upper arch, but this is the lower arch. So just while you were talking about this, Dr. Miller, I was just looking at, okay, did I do the right thing for the treatment plan here? You know, because, you know, we can do the treatment plan without CBCT, but it's going to be a lot of guesswork. We don't know really the roots are going to be inside the bone or they're not going to be inside the bone. So just, I thought I'd show you this case here. Sorry, I didn't want.
That's a great case.
Yeah, I didn't want to take over your presentation.
No, it's fine.
Yeah.
That I believe that the direction of orthodontics, when you start to visualize the shape and size of the alveolar housings, and when you see that you have very small or, you know, compromised alveolar housings, traditional appliances don't work as well as a customized appliance that's based on the cone beam CT. I mean, you know, and, you know, I'm not saying that, you know, you're going to get exactly what you see in the virtual simulation, but you get something close. And, you know, it's that compared to what argument, you know, is there anything else available that can do it better? And, you know, I think that's one of the things that will differentiate us as specialists.
Absolutely. Yep. Thank you very much. Just I wanted to quickly share my screen, show you this. I don't want to.
It's okay.
Oh, that's great.
All right.
I appreciate that very much.
Yeah, sure.
All right. We'll leave it open for any last questions here. I would just like to let Dr. Miller close and just thank him for the presentation tonight. I'd also like to thank Breas on behalf of PreXion for sponsoring. For any of you who currently do not have CBCT in cone beam in your office, we'd be happy to help show you the software, how it works. There's a great deal of information on our website and the ability to request a personal demo for yourself and your practice. Just go to www.prexion, spelled PREXION.com, and you can make the request right there. So again, thank you for your attendance tonight. Any last comments, Dr. Miller?
Yeah, I wanted to say one more thing, Rob.
Yep.
This is Stuart here. I just think that I don't know how many people are on the call across the country, but I think that what Dr. Miller's done here is really important work. I don't know how many people are using this in their practices now and using it like this. Do you have any idea in terms of the number of orthodontists across the country in the US?
There's, you know, you would think that orthodontists would be the first adapters to cone beam CT because we're moving teeth in 3 directions.
Right.
But I guess we don't get paid for the cone beam CT like the general dentist or the oral surgeons. So it's part of our diagnostic record fee usually. So we've been the last to adapt. And there is a general like resistance. I mean, orthodontists have different treatment philosophies. So when the cone beam CT shows, dehiscence, what you get from very smart people is some kind of rationalization that that's not what you're seeing. That's where that 0.6 millimeters comes in. That's where the periosteum argument comes in. So, I mean, I think it's moving in that direction. And I think it's inevitable that it's going to move in the direction, whether the orthodontists, jump on the bandwagon or not, because our patients aren't treated in a vacuum. They see other dental professionals. And those dental professionals are probably going to have cone beam CT in their office. I mean, if you're replacing your Panorex machine, chances are you're going to buy a cone beam because the price is not that much different. And the fees that are generated as a general dentist, you're going to get the cone beam. You're going to take the cone beam of these post-treatment orthodontic patients. And if there's generalized dehiscence, you're going to be able to recognize it right away on the cone beam. So then what do you do? Are you obligated to say something to the patient in absence of tissue dehiscence? I think you are. So think about the general dentist that is doing aligners. We're pretty much treating all crowded cases with expansion. The consequences of that kind of treatment. And, with the Ceph and Pan, you don't know about it.
You're in the dark. Right?
You're in the dark, where with a cone beam, you can easily see it, and they all look the same. It's a generalized pattern. Yeah, thank you. That was a good comment. Well, thanks.
That's it. I think that anything else anybody has, this is a very good discussion. Again, thanks, Dr. Miller. Any closing words?
Well, I think that, I appreciate everybody, paying attention. I mean, and coming and listening to my talk. I mean, especially the people on the East Coast that are up late at night listening to this. I mean, California people still, early. But, I think that the more orthodontists start looking at cone beam, we're just kind of scratching the surface. The more and more information is going to come out, and there's systems like Breus, and there are a few others that actually are now using the cone beam to treatment plan the cases. And I think that's really the direction it's going to have to go because it's safer.
Very good. Well, thank you very much.
Thank you.
Thank you to everyone in attendance one last time here. And again, if you need to, if you need the CEs for tonight's program, please reach out to TJ via the email that Dr. Miller had provided, and we will we'll close this program. Thanks again for everyone's attendance, and thanks again to Dr. Miller.
Thank you.
Thank you, Dr. Miller.
Thank you.
Thank you.
Have a good night.
You too, as well.